I'm going to go ahead and announce that we are calling this meeting to order for the Orthotists and Prosthetists Advisory Board for the state of Texas. And it is 10 a.m. on October the 14th. I want to remind everybody while we're having this meeting to keep your cameras on at all times so we can maintain our quorum. And when you speak, try to remember to say your name first and then speak. And that way it is recorded in the meeting minutes. So with that, we will start with the roll call.
David Arends.
Here.
Mark Kirschner.
Here.
Miguel Mojica. Eric Olson.
Here.
And presiding officer Catherine Mize.
I'm here.
We have a quorum.
All right, thank you very much. The next thing is that we will go ahead and open up the meeting with the open government training, and General Counsel Cassie Sapstead. If I kill names on this, will you all please forgive me ahead of time? We'll do our open government training.
Perfect. You got that correctly, so good job. All right, good morning, advisory board members. Let me share my screen real quick. Okay, everyone can see everything, correct?
Yes.
Okay. All right. Again, good morning, advisory board members. I'm Cassie Sapstead, Assistant General Counsel with TDLR, and I'm here to present the annual open government training. During the training, we will go over 3 different statutes. First, the Open Meetings Act, or OMA, then the Administrative Procedure Act, or APA, and we will conclude with the Public Information Act, also known as the Open Records Act. The purpose of the Open Meetings Act is to ensure open and transparent government. The Open Meetings Act requires notice ahead of the meeting, which includes the time, place, and subject matter of the meeting, and the meeting must be open to the public. The provisions of the Act are mandatory and are to be liberally construed in favor of open government. There are 3 key terms associated with the Open Meetings Act: quorum, deliberation, and meetings. A quorum is simply the minimum number of advisory board members required to be present in order to take official action. You can meet without a quorum, but you cannot take official action without a quorum. Deliberation or discussion means a verbal or written exchange among a quorum of a governmental body or between a quorum of a governmental body and another person concerning an issue within the jurisdiction of the governmental body. A quorum cannot engage in deliberations without complying with the Open Meetings Act requirements. In other words, we are confined to discussing items on the agenda, and we cannot discuss things outside of the agenda because we have to give the public notice ahead of time of what's going to be discussed during the meeting. So what constitutes a meeting under the Open Meetings Act? Well, a meeting occurs at any time a quorum of a governmental body engages in deliberation regarding public business or public policy over which the governmental body has supervision or control, or any time the body takes formal action. As I've already mentioned, the Open Meetings Act requires advance notice of the date, time, place, and subject matter we intend to discuss at the meeting. This notice must be filed at least 7 days before a meeting with the Texas Secretary of State, and it must be posted online by both TDLR and the Texas Secretary of State. So does this mean you can never meet with other advisory board members and have conversations? Of course not. If members of the board meet and deliberate where to have lunch after the meeting concludes, that discussion does not need to be an agenda item. And as it says under item A on the slide, members are free to engage in conversation that is incidental to the event, like where are we having lunch? However, the discussion will be subject to the Open Meetings Act if a quorum of members is involved and the members either engage in a discussion or make decisions about board or committee business or take formal action. Here's some key points to remember. Always be aware of any situation occurring outside of a properly noticed meeting in which a quorum of members is present or engaged in discussion. Don't engage in substantive conversations relating to board or committee business when a quorum is involved and you're outside of an officially noticed and scheduled meeting. Be aware of the walking quorum. A walking quorum occurs when fewer than a quorum of members engage in discussion about official business and then communicate those discussions to other members. You may not have a walking quorum to begin with, but could ultimately end up with a quorum if your discussion with 1 to 2 members turns into forwarding the discussion to other members and so forth. Here's an example, similar to what I was describing. On a 5-member advisory board, 2 members engage phone calls and emails expressing thoughts on an upcoming rule change and exchange research that they each individually performed regarding the issue. One of the board members then forwards the exchange to another member. The members have now engaged in a walking quorum by engaging in that small group discussion outside of a properly noticed board meeting. Walking quorums can occur during conference calls, video conferences, hallway discussions, emails, text messages, social media, Facebook, instant messaging. All of this, again, we have to be aware of the Open Meetings Act. Here are some best practices to avoid a walking quorum. To avoid a walking quorum, you should not meet in small groups. Discuss board or committee business and then communicate those discussions to other members. Send emails or text messages to a quorum of members regarding official business, even if those emails or text messages are sent to each individual member. Don't create posts on social media about board business where a likelihood exists that a quorum of members could participate in the discussions. Or don't ask a quorum of members, even on an individual basis, for feedback or comments on board or committee business outside of the public meeting. This is what we also refer to as polling, which is essentially conducting an informal vote on an issue. And again, we are limited to discussing what is on the agenda, but that does not prevent a member of the public or an advisory board member from raising an issue that is not on the agenda. However, any discussion will be limited to proposing that item to be placed on the agenda for a future meeting. Just keep that in mind during the meetings. Some additional guidelines. To avoid violating the act on the basis of insufficient notice, you should limit discussion to specific agenda items contained in the posting filed with the Secretary of State. Avoid allowing even items that are on the agenda to wander off course and go into new issues that have not been noticed to the public. And do not respond or discuss issues that are raised during public comment but are not on the agenda. And specifically identify items for future agendas and communicate those items to TDLR staff. What are the civil remedies for Open Meetings Act violations? Any interested person, including the media, may petition the courts to stop actions taken in violation of the Open Meetings Act. The Open Meetings Act also specifically states that an action taken in violation of the act is voidable. What about criminal penalties? Well, members who knowingly participate in a walking quorum or knowingly participate in a meeting that is closed to the public are subject to misdemeanor criminal penalties. Those include fines of $100 to $500, confinement in county jail for 1 to 6 months, or both. Again, avoid communications that involve a quorum of board or committee members about official business outside of a properly noticed public meeting. During open meetings, confine discussion to items specifically posted on the agenda. Here's just a list of various resources, including, as always, GC's phone number. Please contact us if you have any questions. So next up is the Administrative Procedure Act, or APA. The purpose of the APA is to establish minimum standards of uniform practice and procedures for state agencies and provide for public participation and transparency during the rulemaking process. For our purposes, we're focused primarily on the rulemaking provisions in the APA. What is a rule? A rule is a statement of general applicability made by a state agency that implements, interprets, or prescribes law or policy, or describes the procedure or practice requirements of a state agency. A rule excludes a statement regarding only the internal management or organization of a state agency and not affecting private rights or procedures. A rule includes a new rule, an amendment to an already existing rule, and the repeal of an existing rule. These are some examples of where rulemaking originates, like legislative changes, advisory boards, that's you guys, TDLR staff, 4-year rule reviews, and rule petitions. Rule petitions do not come up very often, but essentially any interested person may submit a petition to a state agency requesting the adoption of a rule. So what is an interested person? Well, an interested person is anyone who is a Texas resident, a business entity located in Texas, a governmental subdivision in Texas, or a public or private organization that is not a state agency but is located in Texas. Here on this slide, we have a graphic illustration that basically lays out the steps involved in the rulemaking process. I will not go through each one of these steps, but as you guys can see, it's a pretty involved process. And then here we have a graphic illustrating the steps involved in the 4-year rule review process. And lastly, here's another slide with some resources that you can go to. And again, there's GC's number there at the bottom. Okay, last up is the Public Information Act, also referred to as the Open Records Act. The Public Information Act essentially makes all documents, records, and other information related to official business open to the public. There are some exceptions to this, but the general rule is government records are open to the public. Something to keep in mind, this can also mean anything maintained on a personal device that is connected to official agency business. Again, the act should be construed liberally in favor of granting requests instead of withholding. The public may request copies of public information or request to inspect the information in the offices of the governmental body. Requests must be submitted in writing through the TDLR Records Center, which can be accessed on the TDLR website. We have 10 business days to respond after receiving the request, and we cannot ask why someone wants the records. We can only ask for clarifications through the GC Open Records team. It's important that we respond timely, because if we do not, then we can lose our right to withhold records. Here's some common exceptions to disclosure. Again, bearing in mind that the presumption of openness is there, but some of the exceptions include, and will be redacted from records, dates of birth, most email addresses, driver's license, license plates, VIN records, credit card numbers, any HIPAA information, and as it states here on the bottom of the slide, an OAG ruling must be sought to redact or withhold other information that's not included here in these examples. Now let's talk about what happens if one of you receives a request. As an advisory board member, if you receive a written request for records or correspondence that looks like a public information request, please forward the request as soon as possible. to the advisory board team, and they will then forward it to the GC Open Records team. If the GC Open Records team requests information from you as an advisory board member, please respond as soon as possible. Again, that 10 business day deadline applies to all requests. And then finally, once again, another resource slide. This also has our open records policy on here. And again, GC's phone number if you have any questions at all. And that is it for me. I will stop sharing my screen.
All right, Cassie, thank you very much.
Trying to stop sharing my screen. Forgive me, you guys. Can you tell it's my first time? Fun. Okay, let me get out of here.
I would help you out if I knew what to say. But
I'm so sorry, y'all. Okay, there it is. I was waiting for the box to say stop sharing. Thank you guys. I appreciate it.
All right, thank you. Next on the agenda is moving to the approval of minutes of the previous meeting of May 23rd, 2024. So do any of the board members have any comments regarding these meeting minutes? Sorry. That looks like a no. Okay, then we will go ahead and vote on the approval of the minutes. Oh, I need a motion. Sorry, I need a motion.
Mark Kirshner, motion to accept the minutes as they are.
And a second to the motion?
David Arns, second.
Thank you. All right, Carmen, are you going to do the roll call?
Sure thing. David Arens,
Aye.
Mark Kirshner,
Aye.
Eric Olson. I didn't get that, sir. I think you're muted.
Aye.
Thank you. And presiding officer Catherine. Sorry. Wise.
Aye.
Motion passes.
Thank you. Next on the agenda is the public comment period, and we did not have any public comments that were submitted for today's meeting, so we will pass that on. Next item is staff reports, and our first staff report will be from the licensing division. Mary Hoffman, thank you.
Good morning, presiding officer and advisory board members. My name is Mary Hoffman, and I am one of the licensing managers I'll be providing the report for you today. Leonard Rivas, who is the previous licensing manager over this program, has retired, and so I am filling in until his position has been filled. So we are very sad to lose Leonard and hope that he will rejoin us one day. So you have the statistics in front of you. I will just do some brief highlights of what you see there. You have total FY 2024 numbers, as well as the first, second, third, and fourth quarter of FY 25. So I'll just highlight the fourth quarter of FY 25 for licensed prosthetists and orthotists. We have 9 new licenses that were issued. We have 34 licenses that were renewed, and a total population of 340 for that license type. And for licensed prosthetist, we have 1 new license issued, 10 licenses renewed, and a total population of 78 currently. For licensed orthotist, we have 2 new licenses issued for the fourth quarter, 13 licenses renewed, and a total population of 85. For registered prosthetist and orthotist student, We currently have a total population of 58. And then we'll go ahead and just scroll down until we get to the licensed prosthetist and orthotist assistant. For fourth quarter FY25, we have 1 new license issued, 7 licenses renewed, and a total population of 36. On the data also that I have not mentioned is the total percentage of online renewals that were processed with each of these license types. So you'll see that information in your chart as well. And for licensed prosthetist assistant, we have 1 new license issued, 2 licenses renewed, and a total population of 12. Licensed orthotist assistant, we don't have any new licenses issued for the fourth quarter. We do have 2 that were renewed with a total of 26. Now to the accredited prosthetist and orthotist facilities. Fourth quarter, we have 6 new licenses issued, 19 that have been renewed, and a total population of 209, with 99% of those renewals being submitted online. The accredited prosthetic facilities, we have 3 new licenses issued, 4 renewed, with a total population of 29, with a 99% online renewal rate. And to our last license type, it's an accredited orthotic facility. We have 3 licenses renewed with a total population of 9 and 100% online renewal. That is my report today. Do you have any questions for me? No questions.
All right.
Thank you
Very
very
good.
much.
Thank you, Mary.
You're welcome, Catherine.
Next on the agenda is the Customer Service Division, and Myra Rodriguez is going to bring us that.
Good morning, board members and TDLR staff. My name is Myra Rodriguez, and I am one of the managers in the Customer Service Division that oversees this program. And as you can see before you, we have the statistics so far for fiscal year 2026, which is just the data for the month of September, with a total of 38 calls and emails combined. And if you can look at the fiscal year 2025 information, a little bit lower, you'll see the whole fiscal year data for this program. And I'm sorry, let's see. And it's pretty much more or less, we don't see really a big jump in the data comparison for what we have so far for this fiscal year, but I'm available for any questions that you may have. This concludes my report.
All right, hearing no questions. That was quick and simple.
Thank you.
You know what? I have a question really quickly. How many people working in that department are answering phones now?
I believe currently we have we have a total staff of 54, including agents, team leads, a group that helps with the emails, and then our quality analysts and managers.
So the total count is 54. Okay.
We do have
Thank
some
you.
vacancies, but yes.
Got it. All right, then with no questions, we will move on to Enforcement Division. And this is by Shauna. And Shauna, I'm not going to say your last name because I won't say it correctly.
No problem. It took me a long time to learn how to say it, so I don't blame you. Good morning, advisory board members. My name is Shauna Almashuk. I'm a prosecutor for the Enforcement Division, and I'll be presenting the report for you today covering key statistics. As you may recall from the last time the advisory board met, at the top of this report, you have the division's performance measures. And then the next section is the criminal history review for applicants who may have disqualifying criminal history. There is an increase in applicants with criminal history this year, but that has resulted in 0 denials or revocations. The next section details where the enforcement division's complaints come from. And then the top of the next page puts that into a pie graph for you, which is based on the number of those complaints that were opened. And if we jump down to the bottom of that page, you can see that there are no licenses that have had disciplinary sanctions so far this year. And then if we look at the middle section of the next page, you can see that the alleged violations at opening are spread among more categories, but there are fewer allegations in the most severe categories, such as unprofessional or unethical conduct. And finally, at the bottom, you can see that there were no allegations that resulted in violations this time. That concludes my report, and I'm available to answer any questions you might have.
Does anybody have any questions? All right, well then I'm going to ask one. Is there any way for you to tell us how many cases were referred to a expert witness for consultation?
During that time period, just off the top of my head, there might have been one, but I would have to follow up and get back to you on that to confirm.
And how many expert witness, it's not a witness, expert, what's the word I'm looking for?
Subject matter experts?
There you go, thank you. How many of those do we have for orthotics and prosthetics?
I believe we currently have one, but I can double check that as well.
All right. Yeah, I would appreciate knowing that. That would be good.
Yes, I'm happy to get that for you.
Thanks. Any other questions? All righty then, moving on to, let's see, where are we? Licensing, customer service, enforcement, compliance division, and this is Steve Euchre.
Yes. Good morning, advisory board members. My name is Steve Eaker. I'm now the manager in the medical health and wellness section of the compliance division here at TDLR. The subject matter experts, that's something that we always push at when we give our presentations. Please join us, sign up to be a subject matter expert. We had several people who were interested, and hopefully they'll be following up with that. And I know it's between 1 and 3, Shauna. I'm not sure. So let's get through our update. So we've had some changes. I became the manager I was the former program specialist for the Orthotics and Prosthetics program. We now have Ari Acevedo joining us from Education and Examination, and she is unfortunately out of the office on vacation, a long planned vacation. Otherwise, we would have had her here. But we're really excited to have her with us. And we also have Anna Clark, who's the former advisory board team member you may be familiar with, and she is now our team lead in the medical health and wellness section. Currently, we are involved, as are many people here at TDLR, with the bill implementation process. The 89th legislative session passed many bills, and there are a few specific to orthotics and prosthetics I want to run through. Cassie is going to go through Senate Bill 1330 in more detail, but this one, it kind of has to do with billing, and so we thought it's worth discussing. So Senate Bill 1330 is aimed at limiting Medicare and supplemental insurance program costs. It affects providers of durable medical equipment who do not participate in Medicare. These providers may not charge more than 115% of the Medicare approved amount for durable medical equipment and orthotic or prosthetic devices and supplies, unless the patient agrees to pay more. And states that enrollees will not be reimbursed for more than 80% of the Medicare approved amount for the device. And for patients with supplemental insurance, that can cover the remainder of the cost up to 115% of the Medicare approved amount for the device. So there were some real abuses of this, and apparently the legislature took notice. And so that's why this bill was passed. Obviously, people can, and we were just at a conference, and you see people with extremely amazing and fancy prosthetic devices that will certainly cost more than what the Medicare amount is would pay for the basic prosthetic. But this is intended to limit that Medicare payment and abuse. House Bill 216 is about itemized billing for facilities and the responsibilities to now check if a patient needs that itemized bill mailed or to be handed a hard copy. And so this builds on an itemized billing law that was passed in the last legislative session. And that the purpose of this one is to make sure that the providers check to see if the patient actually has access to the internet. And so if you're billing them, it's like, oh, you'll get your itemized bill via email, but this person may not have email or just may not be able to use it or for whatever reason. And so puts the duty or the onus on the provider to make sure that they have that capability. And if not, to offer them a hard copy or mail it to them. Have a hard copy provided via the mail. And Senate Bill 918 is a strategic initiative of TDLR, and that cleans up language in the Orthotics and Prosthetics statute, the Occupations Code 605. And so we have a carve out for people to be able to be licensed via unique qualifications. We often have people coming from other states. Orthotic and prosthetic licensure is not universal across the United States. And we have people with different qualifications coming from overseas. And so this, in the United States, it's often older people, not older, more experienced people who got into the trade when there were no schools really, or there weren't, specific programs and graduate programs in orthotics and prosthetics, or very few. And so these people are competent, they're great caregivers and providers of care. But so that's why we have that carve out for unique qualifications. So what this bill did is just clean up the language. Our general counsel was concerned that it was saying that people were entitled to licensure via unique qualifications, and just because you're unique does not mean you are necessarily qualified. So we've cleaned that up. And other projects we're working on, we continue to assist all of our divisions, enforcement, field inspections, licensing, E&E, and customer service with questions. And we're also working very hard on our new licensing system, which I'm sure will be discussed at some point during this meeting. But we have TDLR is getting a brand new all-in-one licensing system. We have 9 different computer programs that handle our various professions that we license, and we're putting them all in one, and we're very excited about that. So this is all hands on deck. Everybody in the agency has been working on that with our new vendor. In terms of outreach, and also we'll be working with the advisory board and the different work groups as rules are developed to address any of this new legislation. In terms of outreach, we're very thankful for Mr. Olson to allow us to visit his clinic. We sent our intern and Anna Clark there over the summer, and there's nothing like getting some hands-on experience, and we're very appreciative of that. We're hoping to send our new program specialist his way as well. We really appreciate that. And we also went to the Texas Society of Orthotic and Prosthetic Professionals Conference in Richardson, and we gave a talk there and had a table and got to meet and discuss all things orthotic and prosthetic with everyone. Also had a very interesting presentation on the history of orthotics and prosthetics through time, and that was really amazing to see how they've developed just in the last 20, 30, 40 years. As always, if you have any outreach opportunities or any questions, you can reach out to myself or Anna or Ari. And that's all we got.
So does anyone have any questions for Steve? All right. Steve, I think you mentioned this, but specifically for SB 918, will we be forming a work group on the wording for the unique qualifications?
Sure. I guess, and Carmen, as we line up things to do before the next board meeting, we can put that to one of our work groups. That would be great.
Okay, thank you.
Mhm.
All right, upon completion of that, let's move on to Field Inspections Division. And this is going to be brought to us by Lance Curland.
Good morning, board members. My name is Lance Carolyn. I am one of the managers for the Field Inspections Division. I just want to kind of highlight our report for fiscal year 2024 to 2025 for orthotics, for orthotist facilities for fiscal year 2024 to 2025. For 2024, we had 8 facilities that we inspected. For 2025, we inspected 3. For prosthetists facilities for fiscal year 2024, we inspected 16. 2025, we inspected 4. For the combined orthotist and prosthetists facilities, we inspected for fiscal year 2024 125, and fiscal year 2025 we inspected 39. And that concludes my report, so I'm here to answer any questions.
Mark Kirchner, I've got a question for you. So
Yes, sir.
These numbers that you're giving out, so these are year to compared to last year. For orthotic or orthotist process facilities, there's 125 done last year, and we're in the fourth
Yes, sir.
quarter. Is that correct?
Yes, sir.
And then in this year for 2025 fourth quarter, there's only 39 so far.
Yes, sir.
That's a pretty drastic. That's quite a bit of a drop off of inspections. Can you explain why?
Yes, sir. I sure can. We were tasked to come up with the risk-based inspection system for us, and so that's based off on if you've had direct enforcement violations or corrections, the severity of those. If you didn't have any, or they weren't as frequent, we wouldn't come see y'all as much, as far as being inspected on that. And so if you had several violations, the inspectors would be out to come and see a little more often.
So it was based on risk management, I'm assuming is what you're trying to explain.
Risk-based. Yes, sir.
How many inspectors do we have that see the facilities?
We have 42 inspectors total, but as far as that do the orthotics prosthetics, I'd have to get that number for you.
I'd be interested in knowing how many are specifically in O&P. And is there any future going into 26 to try to get back up to this number? I believe on our facility reports, so we've got about 250 facilities in Texas combined, and we're only touching 20% of them yearly. I think that number needs to increase.
Yes, sir. But again, it all stems on a risk-based as far as the facilities.
Yeah.
On when we'd come and visit them.
That's all I had, Catherine.
Okay, Mark, I cannot remember this specifically in the rules without looking, but I thought we had stated in the rules that you would be inspected every 2 years. I don't know if anybody can, I don't want to go through them right at this moment. Can anybody corroborate that?
Mark,
Steve
I'm not
O'Leary,
sure.
Assistant General Counsel. I just wanted to point out that there was a statutory change back in 2021. And section 51.211 Occupations Code was enacted for risk-based inspections. That led to this change that Mr. Caroline is talking about. That it led to us having to base our inspection frequency based on our assessment of risk factors that are identified. There was also a Chapter 60 rule that was done on risk-based inspection. So there's been a change from how they used to be done.
Okay, so then Mark, to your point, I suppose if we wanted to look at that, what we'd actually have to look at is what the risk assessment factors are. Would that be?
I believe, I'm only asking because people are asking me like, how many times do they come by and see us? And there are people that are, I hear from the outside that there are people that don't have people practicing in their office, but we never go by and inspect them. I knew there was a risk management side of it, but I did think that I thought there was something where we were touching about 50% at one time of our facilities yearly. And I mean, at 20%, it brings concern just not knowing if people are in compliance. And does that mean that somebody needs to file an enforcement action or make a complaint to see if my friend down the street, and we're trying not to go back and forth with this, do we want to be reporting our coworkers in the field? And it's more of, are people staying compliant? I'm hearing more and more. Catherine, I know we've talked about this just in, over the last several years. Knee brace manufacturers using outside clinics, and they're still doing this. But if nobody ever turns them in, that's what I've always said is, if you think there's a problem, you need to report them. But nobody wants to report anybody. It just concerns me that we're only touching 20% of the facilities in Texas. That's the only thing.
Excuse me, Mr. Kirchner and Chair Mize, if I could just jump in quickly. This is Steve Bruno, Deputy Executive Director of Licensing and Regulatory Services. And I was just going to add on to what you said, Mr. Kirchner. Sorry about my camera. That yes, while we do have those risk-based criteria in place that Mr. Leary explained, we do respond to complaints. And so we do encourage folks, if they see something or believe that there's something that should be investigated, to please go to our website. Right at the top of our webpage, there's a box that says file a complaint, and it gives you an opportunity to then select which program you want to talk about, and fill out as much information as you can give us. And we will look at that. So in the secondary heading on our webpage is complaints and enforcement. And then the first link there is going to be file a complaint. And we would encourage folks to do that, so that in addition to our risk-based inspections, we have that information. Thank you.
Thank you. Appreciate that.
Thank you. Anybody else have any comments or questions? All right, hearing none, we'll move on to executive office. So Mr. Bruno, would you like to take it from here?
Sure. Thank you so much. And thanks everyone for being here today. My name's Steve Bruno, Deputy Executive Director for Licensing and Regulatory Services. Just wanted to share some agency-wide updates. The biggest one I want to begin with is some organizational changes that happened to us over this past legislative session. As many of you know, if you've been with TDLR for a while, it seems that every legislative session we get some work added to our plate. And in this case, it was the addition of lottery, the state lottery program, and charitable bingo. Those are no longer their own agencies. They are part of TDLR. We've got a transition team in place that's working on that. And so far things have been going very well. It has pretty much doubled our FTE count, and we are merging and mingling with our new fellow employees from lottery and bingo, and they're doing the same thing for us. So big change that we're working through, and we're excited about. The other one I wanted to notice, Mr. Steve Eaker noted this earlier. We are working on what's called TDLR Core, and TDLR Core is our licensing system replacement project. As Steve mentioned, we have a multitude of systems now. We have some things available online, some things not. And so we are transforming. It's about a 3-year project.
It's going to consist of what we call waves, whereby different programs are brought online at different times. We will keep you updated as this progresses, but we're very excited about it. We believe that it's going to bring great benefit to both our licensees and to our own staff as we continue to process applications. Just a couple of highlights from the last fiscal year. We've just passed over 1 million licensees when you consider all the facilities and the people. So growth continues. The last thing I want to note for this report is that the chairman of the commission would like to schedule brief meetings with each advisory board chair, and he'll be reaching out to facilitate that if he hasn't already. But otherwise, I just wanted to say thank you for being here, and I'm here to answer any questions or comments that you all have.
Is TDLR now the largest agency in the state of Texas government?
That's a very good question. Our responsibilities are quite large. As far as FTEs, there are definitely some larger agencies. I think the Department of Transportation comes to mind, and probably some others. But we definitely have a large variety. We've got 42 programs total now when you add lottery, which is the regulation of the installation of solar panel installers. You may have heard or seen or even been solicited yourself to install solar panels. We already have the electrician program, and so that fit nicely. The legislature was very concerned about, well, frankly, about people being ripped off, right, and not being given what they're supposed to. So that's a new program in place, so that it does bring us up to 42 programs, Chair. So yes, it's quite a lot.
Wow.
Yeah.
All right. Thank you very much. Any other questions?
Thank you.
All right. Hearing none, we will continue to move on.
Thank you.
Yes. So next on the agenda is the discussion and adoption of an enforcement plan. And John Medlock is going to present this.
Yes. Good morning, advisory board members. Again, my name is John Medlock. I'm the chief prosecutor for the enforcement division. I'm going to present the updates to this penalty matrix. I'm going to share my screen so you guys can see it. Okay. Hopefully that is sharing now. Okay. As a reminder, the penalty matrix kind of serves as a guide not only to the industry, but also to the public to kind of let them know where different range of penalties and or violations might be. It also aids in the consistent application of penalties or sanctions so that similar situations are treated similarly when they come across a prosecutor's desk. First, we break things down into classes. So as you can see here, we had a class A, and sorry for the scrolling, but as you go down, we have other classifications such as class B. That is the major kind of subheadings for each of these different ones as they go down in classification. So class A being the least severe, class D being the most severe. The other thing you will notice is that we try to group violations under similar headings so that people can easily find if they are encountering an enforcement action against them. They can kind of easily see where not only what classification, but what group heading that they might be under. The other thing that we do is once we lift all the statutes and rules into this document, we kind of plain talk it. So as you can see there, the violation of fail to wash hands with hand sanitizer, soap, and water before providing service to a patient. That's not what the actual law or statute says verbatim. We put it in a plain talk so it's easily understandable. But we also do put that citation there next to it so that people can easily go look up what that particular violation might be, either via rule or via the statute. What we did with this one is this one had not been updated since 2017. So what we have done is we've gone through and made edits to any rule numbers, letters that might have been changed over the course of time. Also went through and added any additional laws or rule citations that have been added since that point in time. There really were only the major part of the changes were just updates to, like I said, the citation lettering, but not much of anything in terms of adding new rules. A couple of things to point out is under our Class C violations here. We did add, sorry again for the scrolling, a section related to continuing education violations. Those do fall underneath our Class C type violations. And then ultimately the last kind of major updates were these last two failure to cooperate type violations. And that's just to kind of standardize it with where some of those failure to cooperates fall with our other enforcement programs that we do maintain. So we kind of fall those into that higher classification of violations. So again, like I said, the vast majority of the updates were just to those citations with the addition of the continuing education and moving the failure to cooperate type violations from a Class C to a Class D. I would ask that you guys would vote to approve this matrix and recommend sending it to our commission for their ultimate adoption and implementation by our team.
Okay. I'm just taking a minute here to read through them. I couldn't tell originally what was new and what was existing from the
Like I said,
original.
yeah, the only things that were new, I think there was one additional thing that was new, other than the CE provisions, and that was due to a statutory change, and that was under the Class C record keeping violations. The last two, the facility failed to provide itemized billing to patients prior to pursuing debt collection efforts against the patient, and failed to include all required information on itemized bill. Those provisions were added from a Senate bill, I think, in the 88th session, so 2 sessions ago. But other than that, like I said, the vast majority of it was just cleanup in terms of the citations. And then, like I said, the addition of that CE violation and the movement of those ones in the Class D.
All right. Does anybody have any questions, or do any of the board members want a few minutes to review, or are you all comfortable in a motion for a vote?
I'm comfortable. Thank you. I read through this when they first published it.
Okay. Anybody else? David, Eric, are you all comfortable? If you're talking, I can't hear you.
Yes. Yes, I'm comfortable also.
All right. Well, then
Apparently
if I
my
can
micro, I was going to say, apparently my microphone times out and becomes muted.
okay. If you all are comfortable, let's move forward with a motion for approval. I need someone to make a motion for approval.
Eric
So-
Olson, make a motion to accept this.
David Aaron's second.
All right. Then Carmen, will you do a roll call vote, please?
Yes, ma'am. David Arens,
Aye.
Mark Kirschner,
Aye.
Eric Olson,
Aye.
Presiding Officer Catherine Mize.
Aye.
Motion passes.
All right. Thank you.
Thank y'all. I appreciate it.
All right, next on our agenda is a presentation by Hanger Clinic. It's titled The Scope of Practice and Supervision of the Texas Licensed Assistant. And we will follow this presentation with some discussion. So Eric, would you like to introduce the presenters from Hanger?
Yes. Robert's going to introduce everybody, I believe. Correct?
I got you, Eric. It's all good. Is that okay? If I go ahead and just jump right into it?
Go right ahead, Robert. Thank you.
All right. Good morning. Thank you all for allowing us this time to discuss the licensed assistants who are going to be so critical to the future of O&P. Like Eric mentioned, my name is Robert, last name Chung. I am a certified prosthetist by training. I started sweeping the lab in high school when I was kind of getting into the industry. I am currently Director of Clinical Operations at Hanger Clinic. I'm a member of the AOPA Coding Committee, and I am a former California Orthotic and Prosthetic Association board member. Main goal for me getting my MBA was advocating for clinicians, so I'm honored to be here. I want to quickly have my colleagues introduce themselves. Maggie?
Sure, yeah, thanks, Robert, and thanks everyone for having us today. So I'm Maggie Bomber. I am the leader of Enterprise Patient Advocacy for Hanger, which is a national role focused on advocacy efforts related to patient access to care. I also have a background on some of the national O&P boards, the NAOP, and I'm on the AOPA work group, CRO work group. Lawyer by background, and recently got my executive MBA just to kind of enhance my knowledge and understanding of kind of working in a larger corporate space. So, Erin.
Hi, my name is Erin O'Brien. I'm a certified prosthetist orthotist. I'm also a fellow of the American Academy of Orthotists and Prosthetists. I work for Hanger in sort of a clinical education capacity, but I also serve as a director on the board of directors for the American Board for Certification. I'm also the chair of their scope of practice committee for all the different scopes of practice that are certified within ABC. And so I'm excited to present to you today on all the ways that the assistants in Texas can enhance clinical care and patient care.
Thank you, Erin. Go ahead.
Robert, you're on mute.
Still getting used to the WebEx thing, used to Teams, like I think someone mentioned here before. All right. So now I'm sure some of you are asking, how did we get here? Frankly, it started with Eric approaching us with a story. It was a story about a resident who came to him about his future earning potential and the challenges the resident is facing in the workforce and meeting demands and work-life balances. And I'm sure Eric will be glad to tell you that story at a later time. But in short, Eric asked for our help reviewing the rules and providing guidance to that individual, and then maybe helping assist secure that young gentleman's future and those like him. So that's why we're here to talk about these rules today and recommend some potential changes. Like most of the medical industry, by most, I mean almost all, patient demand is outpacing clinician supply in an environment of greater education costs and downward reimbursement pressure. In a study NCO published from 2015, it was noticed that workforce would only go by 8%, while demand would increase by 14%. That is a huge gap. Many of you guys who practice can feel that reality coming true. So to ensure our patients' needs are met, our clinicians have to find more efficient ways to provide the same level of high quality, compassionate care while facing greater documentation requirements and other administrative demands in addition to that increased patient population. I want to also quickly highlight that on the right, you have two graphs. The orange line is patient demand for, on the top, PM&R physicians. On the bottom, orthopedics physicians. Blue line is the physicians. You can see there's a gap in that space. We are also facing encroachment in O&P from other DME and other providers who have gained a presence through Medicare's competitive bidding program. Next slide, please. Now, these numbers I find very interesting. Hanger was one of the largest O&P bid winners, but we were in the minority of overall bid winners. In these numbers, I've removed our numbers because we have a fairly high physical presence in the state of Texas. So it skewed the numbers a little bit. But to highlight this encroachment, I want to call out the number of out-of-state DME companies that were granted off-the-shelf contracts to Medicare beneficiaries during the round 2021 program. That's 63% of the spine and 53% of the knee bid winning locations were listed with out-of-state license or addresses. With the industry and our patients in mind, we present to you a set of rule recommendation changes that will allow licensed and certified clinicians to better utilize licensed assistants in ways that are consistent with other medical professionals like the dentist, the optometrist, the physical therapist, the surgeons, the physicians, all those valued healthcare professionals I know all of you interact with. We also want to make these recommendations in order to better meet the demands of that growing population that we talked about. Increase our earning potential that better matches the investment they made in their master's level education, and align with ABC's scopes of practice so that there's better adherence and without any changes to the quality of care. So that being said, let's get into kind of those recommendations. I'm going to turn it over to Aaron here and Maggie to walk us through those. So next slide, please.
Okay.
Yeah, thanks.
So I'm. Oh, go ahead, Maggie. Are you
Sorry.
taking me?
Thanks, Erin. So we were just wanting to make that update specifically as it relates to the scope of practice for the assistant license. And we believe this can be done without actually updating the statute, Chapter 605, Section 255, but rather making an update to the rules. So you can see here on the screen on the left, the definition of assistant license speaks specifically to an assistant license under this section may only provide ancillary patient care services as defined by the commission by rule. So our proposal is to update that definition of ancillary patient care services, which you can see on the right specifically excludes critical care events. So we're saying if the TDLR could propose to the commission to actually strike the assistant patient care service definition and roll it up into the ancillary patient care service definition, we believe we could make this change in the rules rather than changing the statute. And with that particular change, it corresponds with several other definition changes. So they kind of all fall together and follow suit. So those other definitions would be the critical care events, the direct supervision, the indirect supervision, and the off-the-shelf definitions. So if you go to the next slide, we list here on the left, sorry that there's so much text on here, but we figured you guys would be looking at these slides after the fact and wanted to have it all in one place. So on the left are the current rules and the current definitions of ancillary patient care service and assistant patient care service. And then on the right is our proposed change of the combination of those two, which you can see would renumber the order as well. So since 3 and 4 are becoming 1, it would now be 3. So the other definitions that follow on the other slides are renumbered as well. But yeah, Erin, if you want to speak to the new proposed definition and how that relates to the ABC scope of practice on the bottom of the slide.
Sure. So we wanted to be cognizant and respectful of the existing rules that are in place under the current Texas licensure board. But we also wanted to sort of update them to reflect current practice and the standard around the rest of the country, which tends to be the ABC scope of practice because they are our national certifying body and accreditation body. So ancillary patient care service, which is the part of that is actually mentioned in the actual statute, so we have to keep that definition, would now include clinical and technical activities associated with the provision of prosthetic and orthotic services. That is all exactly the same. That's taken directly from your current rule. But this is where it would change slightly, including both critical and non-critical care events. Everything after that, exactly the same. We're not changing that language, but we wanted to specify that this would take place under indirect supervision of a practitioner licensed in the practice area which the service is being provided. So what this is doing is expanding the scope of the assistant slightly, still under supervision of a licensed professional, a licensed orthotist or prosthetist, to make sure that adequate and appropriate patient care is happening. but to allow better access of our patients to patient care, and to support our existing clinics and clinicians to be able to provide the patient care in a timely fashion. You can go ahead to the next slide. So critical care events is one of the portions that we took a look at, and it really, right now, critical care events are completely carved out of the scope of the assistant. The assistant is not allowed to participate in critical care events, which include basically any part of practice that has to do with a custom device. So other than shrinkers for a prosthetics patient, that is all of prosthetics, is not allowed to be participated in by an assistant. And for orthotics, it's all custom devices for an orthotics patient. What we'd like to see is that critical care events are now allowed or included in the scope. Again, these are all going to be supervised by a licensed clinician, an orthotist or a prosthetist. So there's always going to be someone overseeing all of this care. But we propose that the critical care events are now included in the scope rather than carved out from the scope. So you can see on the right side, the industry standard that we have defined is the ABC Certified Assistant Scope of Practice. Interestingly, the requirements to become an assistant, a licensed assistant versus a certified assistant, are fairly similar. Your education requirements are actually slightly more restrictive. There are more requirements that are needed to become a licensed assistant in the state of Texas. The number of experience hours is the same between the two certifications or licenses. And so what we're trying to do is really honor that education that's required and the amount of experience that's needed to use these professionals in the best way that we can to provide good patient care and safe patient care in a timely manner for our patients. You can go ahead to the next slide. So something that's a little bit unclear, and this is my opinion, maybe all of you are very clear on direct supervision versus indirect supervision in the Texas rules. But we wanted to clear up that definition slightly to make sure that people really do know what supervision is required of them for these different types of care. So what we would propose right now, direct supervision is listed as supervision that's provided to a clinical resident, that is a resident of a clinician path or an assistant path. Throughout the delivery, fitting and delivery process, including oversight of results and signing off on all aspects of fitting and delivery. It's not explicitly stated in this rule, but it is fairly clear in a different rule that the implication here is that direct supervision means the supervisor is in the room with the person that is providing the care. That is very different from ABC's definition of direct supervision. So you can read what that means, but ABC requires that someone is on hand in the building or available by real-time video and audio consultation. So that means they would be on a Teams or a WebEx call with the person to review the results of the care while the patient is still there. So if you are seeing a patient under direct supervision, my supervisor would actually have to come in at some point to that appointment, review the results of my care, and sign off on my notes to say, yes, I approve that this is what happened. That just allows a clinician to actually be doing their clinician job at the top of their license, right? If they're in the room with the person that is being supervised, they can't do anything else. We know that there's a shortage of clinicians. We know there's an excess of patients. So we have to figure out a way to bolster the career field, basically the people, professionals that are available to see our patients. And by tying that clinician into the room with their assistant, it really limits how many additional patients we can see in a day. So we can move to the next slide that talks about indirect supervision. So currently indirect supervision in the Texas rules reads very much like direct supervision in ABC's rules, in that someone needs to be on site to be supervising in an indirect capacity. What we would suggest is that we would update that to allow for the clinician to be offsite or the assistant to be offsite, but they are able to get in touch with their supervisor via phone or real-time video audio contact during the patient appointment if there are questions or if anything needs to be confirmed with their supervisor. So we're really just taking the supervision limit definitions that you currently have and tweaking them slightly to really allow the expanded access of patient care by allowing our assistants to see some of these patients with the appropriate level of supervision that is due with their experience and education levels. We can move to the next slide. The final proposal that we have is around the definition of off-the-shelf devices. And this has to do with our assistant population, but it really has to do with the entire clinic population. Currently, the rule for off-the-shelf devices, which is a very small subset of codes, it's very well defined of which codes are off the shelf. This isn't all prefabricated devices, but it is a prescribed prefabricated orthosis that requires minimal self-adjustment by the patient or a personal caregiver for appropriate use and does not require expertise in any of those things, right? So we've already said that it requires minimal self-adjustment and it doesn't require trimming, bending, molding, blah, blah, blah. Right now, under the current rules, the assistant has to be supervised under indirect supervision to see this type of patient for an off-the-shelf device. However, in any other facility, let's say this person goes to a pharmacy, same patient goes to a pharmacy versus an O&P facility. If that pharmacy or other facility doesn't fall under the same TDLR rules because they aren't that type of facility, anyone in that office can see the patient for an off-the-shelf device. Because Medicare, we're using the CMS definition here as an industry standard, Medicare states that because there is no expertise needed, no one that has expertise needs to see this patient. These devices are very, very simple. They're usually very low cost, but they don't require adjustment by an expert. Anything that needs to be done can be done by the patient or a caregiver for that device. So what we're proposing is that TDLR allows that same flexibility for the provision of off-the-shelf devices. And that really is to protect the O&P and the DME providers in Texas from encroachment from these other professions that right now don't have any sort of limitation around provision of these devices. We'd much rather have those patients come to a facility where someone that has been trained can provide them and provide them in a way that's still supervised by their licensed orthotist or prosthetist, so that they really are getting appropriate patient care in a safe way. And we don't have other people sort of providing these devices to our patients in a less safe manner. You can go ahead to the next slide.
Yeah, so to summarize everything that we just went over, these are the main bullet points here of really we're talking about amending the rules under Chapter 114. So combining that ancillary patient care service with the assistant patient care service and allowing for those certain services to be provided under indirect supervision. Again, removing that off-the-shelf definition, as Aaron was speaking to. As far as critical care events, really making sure that that extends to the licensed assistant and that it's minimally requiring indirect supervision. And then just ensuring that as far as direct supervision goes, that it's very clear that that can either be on-site or via real-time audio or visual supervision. And then the indirect supervision is clarifying that the person that's the supervisor must be available for consultation throughout the process, but not necessarily needing to be directly in the room on site. And then finally, the off-the-shelf definition that just clarifying that these devices really don't require clinical judgment, and we want to be able to enable the licensed assistant to provide these types of devices. So the next slide.
We can just leave it here, Maggie. Oh, sorry. Got ahead. Missed this slide. Please continue.
Yeah, so we were just kind of summing up when we had spoken earlier about some of the key factors that you all consider and um, determining whether to make a rule change, that there are certain categories of information that you look at. So as far as a public benefit, we believe these rule changes would provide a public benefit by enabling more Texas residents to have access to care more timely and more efficiently. We don't think that there's any particular cost associated with this change other than potentially administrative costs of, going through the rule changing process and updating materials. But those costs would likely be far outweighed by the increased number of patients that we're able to see more efficiently. We don't believe there would be a direct impact on any other professions. This is really focused on O&P professions and how it would enhance our ability to provide timely care. Other states have adopted similar changes. And again, we believe that if we approach it in this way, that it's really about a rule change and not a change to the statute. So I think the next slide is yours, Robert.
Yeah, and we had already talked about kind of briefly the slight differences between education standards, and we are continuing to honor those, as Aaron said. As we conclude this presentation, I want you guys to kind of think through a scenario here where a patient enters into an office and is greeted by the front office staff, and an assistant takes them back, takes their general height, weight, general demographics, things along those lines, has prepared the room for that patient, and has made sure that that patient is comfortable and ready to see the clinician, begins to kind of conference with the patient, and then has a conference with the overseeing clinician. The clinician comes into the room, begins to diagnose the patient or create a treatment plan. The assistant then performs a couple routine tasks, and the clinician comes back to either implement those or ensure that they are done in a very compassionate and effective manner. The assistant helps with documentation. The assistant helps with ordering of the components or ordering of different things. The assistant helps with scheduling the next appointment or providing the patient with instructions. Now, you may be thinking I'm talking about, our changes recommended here, and I am, but I'm also talking about every other experience that you guys have with those physicians, those optometrists, the dentists that you talked about. So in those instances, there is opportunity for higher levels of patient care and alignment with what we do with the general medical industry, further proving we are those professionals that we present ourselves to be. So with that, we open up to any questions you guys may have. And Stephen, we're right at 20, so I defer to you on the time management here from on out.
Thank you, sir. And what I suggested is that to keep the presentation itself at 20 minutes, because we want to reserve time for questions and discussion with the board members. And then once they're through with that, I'm going to suggest as part of item L that that the board recommend that the changes that have been suggested today be reviewed by a work group. It's one of the many items we're looking at updating as part of possible rule changes. So, at this point, let's open up to the question and answer from the board.
I have one quick point that I want to bring up. Steve, do we need to have do we need to open this up for discussion with a motion, or can we just openly discuss?
I think it's properly noticed up, and you can open it for discussion. So this was just an informational presentation. Really, nothing's being adopted today. So I think you can just discuss.
All right. Very good. So I'm going to open it up to others to start the discussion. Anybody on the board want to open this?
Yes, I've got a question for Aaron. Aaron, is it your understanding that a licensed prosthetic assistant, according to the way the rules are currently listed, can provide a shrinker, and that's pretty much the extent of their scope?
Yes, that is correct. Under the current rules, The only device that is allowed to be provided by a licensed prosthetic assistant is your shrinker. And one thing that I'd like to point out is that for either a prosthetic or orthotic assistant, currently under the rules, giving patient instructions is actually a critical care event. So your licensed assistants can't even go in after a definitive device has been delivered and go over very simple and routine wear and care instructions. So right now their scope is very, very limited, especially the prosthetic assistant side. And I think we're doing a disservice to our patients and to our professionals in the industry by kind of limiting them that much in terms of their scope. But yes, that is correct. They can only provide shrinkers.
And on the orthotic assistant side, critical care events is developing the prescription and delivering the device.
It's anything that has to do with a custom device. And importantly, our change or our suggested change to the scope still leaves the formulation of treatment plans. So the actual device prescription development, the decision on what we're actually providing to the patient remains with the licensed prosthetist or orthotist. That is not given away to the assistant. That is a one portion of the treatment care plan that really needs to stay with the licensed clinician. But the remainder of the portions of the process, let's say taking a cast for an AFO, would be allowed to be performed by an assistant still under supervision.
So I also have a question for Robert. Robert, a master's degree for this to become a licensed orthotist prosthetist is running around 70,000 currently.
You know, it varies based on kind of the school that you attend and the degree of additional education you have to. But yes, that is correct. That's what I found based on the research of I think it was Cal State Dominguez Hills is running around 70,000 right now.
Okay, because as a clinic owner in the past, having a private business for 25 years, I found that a newly licensed orthotist prosthetist was able to generate about 500,000 a year in sales mixed O&P. And that really only allows for a salary of $50,000 to $60,000 a year, which I think everybody would agree is kind of the industry right now. They have increased the master's degree, or the orthotic and prosthetic certificate now has to have a master's degree. And my understanding is that was to increase the education level so that the people were more qualified to be able to supervise a staff of assistants. Is that correct? Is that what you're thinking?
Correct. That's my understanding, that it was to elevate the profession and begin to present themselves on the same level as doctors, physicians, PTs, etc., where they, as we kind of discussed, oversee the overall treatment plan of the patient through its provision through licensed assistants in this case.
Aaron, is it my understanding that ABC currently is stating that one of their ABC certifies is capable of supervising upwards of 3 assistants?
The current ABC rules that are in place only allow for supervision of up to 5 assistants or care extenders. That would include an orthotic fitter, which is not a licensed position in the state of Texas, so you don't necessarily have to worry about that. But the ratio is up to 5 care extenders in the office under one supervisor.
Catherine, can I share just a quick anecdote?
Sure.
Is that okay? So I had a resident that finished his residency, and he spent a lot of money becoming an orthotist prosthetist. He's out of San Antonio, and he came to me practically in tears. And he said, I'm engaged. I want to get a house. I want to provide for a new wife. I want to do all this. And I just got my salary stated to me. And it was in that 50, 60,000 range. And he was wondering if he had made the worst decision of his life becoming an orthotist prosthetist, to spend 70,000 and to make drastically less revenue than other professionals in Texas. I explained to him that the rationale of having a master's degree now is that you would be supervising upwards of 2 or 3 assistants that were each making and producing 500,000 a year, which would equate like a 1.5 million in revenue. Now, those kind of numbers would justify a salary of 150, 175, which is much more of a professional wage for the state of Texas. As everything is sitting right now, I explained to him what I've been trying to do as a board member, which is to make the assistant program and the assistant position more feasible, where we can have people with associate's degrees and good education and a health alliance to be able to be seeing these patients, and for this young man to actually work at his level of master's degree, supervising other people as they care for all the patients and not having to glue in pads and replace Velcro straps, but actually be creating care plans and follow-ups and solving problems. So this is what I would really like to see. As everybody knows, in Texas, we have huge areas that have no coverage. And if each of our licensed practitioners took on 2 assistants, we would quadruple the amount of care given to the state of Texas. And when the other day I was at Scott and White, and the physician asked me, where do I get compression hose? Where do I get diabetic shoes? Where do I get these off-the-shelf items? And I said, I cannot provide those services to you because we do not have staff to be able to do it. There aren't enough certifies in the state of Texas to even provide the services to our population. So I would love to see, when we do this work group and all this, that we create feasible ways for assistants to become licensed, and then to open up the scope of practice to something more reasonable that reflects the national standards, and just make the repairs. There is a ton of urban legend out there regarding our assistants. We have dozens of prosthetic assistants in the state of Texas. I'm certain they've done more than provided a shrinker. And there are dozens of orthotic assistants, and I guarantee that they are not working under direct supervision and the practitioners in the room with them during all critical care events. So anyway, this is the goal. This is why I invited these very intelligent, very well-rounded people to help us create this, if that's good. So anyway, thank you.
So thank you, Eric, and thanks to all of you all from Hanger for your very thoughtful presentation. I will advise that this go to a work group for some very detailed work and discussion around it. But let me, if I can, very quickly give a little bit of background information here. I believe I'm the only one still on this advisory board who was here when we moved over to TDLR and when these rules were rewritten and the intent with which they were written. And I was a part of that group. So let me give you a little bit of background. And that is that, and I realize that everything is subject to interpretation, but the intent when this was written on critical care events was that a licensed assistant could do more than what has been described by you all here. So the intent was that they could take the cast or take the scan of the patient. The practitioner, the licensed practitioner, would be involved in the initial patient assessment, as it is stated in the critical care events, in determining whether the prescription that has been received is appropriate or if it needed to be changed, they would be in charge of reaching back out to the physician or person that wrote the prescription to discuss a change in that recommendation. But then at that point, they could leave the room and the cast or the scan could be done by the assistant. If there are any fittings that are involved in the process of providing the final brace, the assistant could also conduct any of those fittings. The final dispense, fitting, fit, function, and delivery of the orthotic or prosthetic custom device could be done by the assistant as long as the licensed practitioner is there on site to come in and double check that the education that was given, have a conversation with the patient. Do you have any questions about your education on how to use this? Let me do a final check on the fit and delivery or alignment of the device. Yes, it all looks good. And then they, with their eyes on it, can approve it and send the patient on their way. So it was designed with the thought of using the assistant at a higher level than what you all have described here. So I just
Can I
want to
comment on that?
Sure.
I fully believe that this was written with the best of intentions. I think probably what's happening is that the language may just need to be updated to reflect what you initially intended. In the rule as it's written right now, education is specifically pulled out as a critical care event, which means that the assistant cannot do it. The assessment of fit and function of the custom fabricated prosthesis or orthosis is pulled out specifically. So I'm wondering if the intention of what we were trying to write, and when you're writing in legalese, I'm not a lawyer. Maggie and some of the other people on this call understand it way more than I do. I fully appreciate that things can get very tricky very quickly when you're trying to write in a way that allows certain things and restricts others. If the intention was what you just said, I think if we can just update the language so it's more clear, we'd be in a much better place for the folks that are in the state of Texas. If you're following the letter of the law, which is really the rule, right? Those things don't appear, at least to me and the other folks that have reviewed it, to be allowed. So I would love it if your original intention was just reflected more, I don't want to say accurately, but in a more precise way, so that if they truly are allowed to do those things, that they feel some comfort by being supported by the language of the rules, so that they know that they can do those things legally.
Yes, and I would like to also say, in addition to that, Aaron, that the direct and indirect supervision, I would like to closely look at, because I do agree with the definitions as ABC has put forth on the indirect, and I would like those better applied or applied word for word, actually, to our rules.
Catherine, one thing I'd love to see, which, we had a lot of misgivings putting this together because, I'm with Hanger now, and these people are just such incredible resources that I just felt like I couldn't put this together by myself, and they've helped me. And then also Aaron represents or is with ABC, but doesn't represent. And we don't want TDLR or licenses to reflect ABC directly or reflect Hanger directly or anything. We want it to be its free, independent deal. But currently, the way everything's written, someone that's an ABC certified cannot read the rules and read the requirements and understand them. I'm fielding calls constantly from all sorts of people over Texas asking me, can I do this? Can I do that? Am I able to do this? Am I able to do that? So I think for the industry as a whole in Texas, if it does reflect more of the ABC language, which is everybody seems to understand much better, that compliance would be higher. There won't be so many gray areas. It would really cut back on the urban legend of what people can do and what they can't, because the stories I get are just outrageous. And I think they've done a very good job of helping make those changes that we can review in that work group, but it's all included in the slides and everything, because one of the things they spent hours, endless hours, yeah, endless hours going through everything and trying to figure out a way to change it, make it all apply, but not change the statutes, but just change the rules by very minimal verbiage changes to keep it just as simple as possible.
Right.
So,
Yes. And I can also tell you that when we were doing this in the beginning, while we wanted to use and did use ABC as a guide, we certainly did not want to tie our rules to ABC, because if you do that, when ABC makes a change, then you're forced to make a change through rule change here, which can be extremely onerous. So we definitely avoided that.
understood. Good planning.
Yeah. Mark, do you have any comments, or David?
It's Mark here. So I think that this needs to go to a work group and try to see if there's a way that we've talked about this in the past to see how we can try to open this up a little bit. I think it is just the wording, the wording's coming through. As we've gone through, like on the enforcement side, we don't ever see any complaints from assistants, having a complaint filed against them. I don't know if that means that they're doing great or if there's just not any of them out there. But I'm willing to, I think through a work group, maybe, let's look at it.
Okay.
This is David Arns. As a prosthetic user, my main concern is what's best for the patient. I would hate to see some kind of rule change about an assistant causing a degradation in care for the patient. So that's my ultimate thing, and that's why I would agree with Catherine of sending it to a work group. As far as what assistants are paid, is there some kind of legislation or something that limits what they can be paid? And if not, I think that falls back on the companies and the practitioners and the clinics. I don't know what that would have to do with the rules, but again, my main concern is patient outcomes and making sure.
Yeah, we agree fully that the patient has to be the center of everything that we do. For a licensure board, for an accrediting, certification board, any of those things, we are here to serve patients. So we have to make sure that their safety is priority number one. The hard thing right now is that with the access to care issues that we're having, we are currently delaying patient care for patients because we don't have enough people to see them. And so if we have people that are appropriately trained and supervised to see patients at an appropriate level, that allows them to be seen sooner, which I would argue is safer for the patient than delaying their care overall. Now we have to make sure that that person that's seeing the patient is trained appropriately, which you have, regulations in place to make sure that's happening, that they're supervised appropriately. Again, we would have, legislation in place to say that that's happening. So there has to be guidelines around this and guardrails, because yes, patient safety is number one. No one wants to see a patient get hurt for any reason. So I think the work group will absolutely, I would imagine you will keep that, kind of center of mind when you're working through these. But I think there are ways that you can expand the scope and still keep patients safe and improve their access to care, which hopefully will improve their healthcare, experience overall. And then if I could just comment quickly on the salary issue. I think the question.
If I may, Cassie
Yes.
Sasta here, Assistant GC with TDLR. Sorry to cut you off, Aaron, but I know that we don't have the salary piece. I know it's come up a bit today, but it's not on the agenda. So I want to steer completely clear of that right now. And while I have the floor, sounds like we're all in agreement about sending this to a work group. So we've kind of got a packed agenda here. So I just want to try to nudge us along if we can. Thank you, guys.
Thank you, Cassie. And this might be good for the standard of practice work group. We several different, when we get to item L, several different possible rule changes we're going to look at. Some things that are suggested during rule review. There's a uniquely qualified individual piece we heard about today, and the Senate Bill 1330 piece about Medicare billing. So they don't all necessarily have to go to the same work group, but what we're hearing about today seems like it falls into the possibly the standard of care work group. So I appreciate that, and I hate to cut anyone off, but we had kind of budgeted about 20 minutes for the for this on the agenda.
All right. Well, then, given that, we will, unless there's any strongly opinionated last sentences, we will close this discussion and move on in our agenda. And this will be recommended to a work group for discussion and then brought back for findings at a next meeting when appropriate. So thank you very much for bringing this to our attention.
Yeah, thank you all
You're
for
welcome. And
having
then
us. Thank you.
thank you. And then I assume that we are now okay to drop off the call and let you guys continue on business.
Yes, sir.
Thank you very
Very
much.
good. If there's anything else we
Thank
can
you.
assist with, you have our emails. Thank you.
Thank you.
All right, so moving on our agenda, the next item is Education and Examination Work Group Report, and that will be brought to us by Cassie again.
All right, let me share my screen again. I think I can do it this time. Okay, let me get the report up. Sorry, it wants me to jump ahead to the rules really badly. Okay. All right, can you guys see the education and examination report in front of us? Okay.
We can.
Again, Cassie Sopstead, Assistant General Counsel with TDLR. I am going to go over the education and examination work group report, shifting gears a little bit, but still talking about assistant licenses here. During the advisory board meeting held in May of last year, proposed changes to Rule 114.27 regarding the assistant licensee education requirements were discussed. The proposed changes were then sent to a work group, and that work group met on June 12th last year. The work group discussed the issue presented by the current rule, that is the requirement of 3 hours of college physics. And the work group also explored other alternative educational pathways that would meet the statutory requirement of education in the physical sciences while also removing an unnecessary barrier to entry to the occupation. In short, the work group recommended a pathway which would allow applicants with associate's degrees, including substantial coursework in anatomical, biological, and physical sciences, to satisfy the educational requirements of the rule. And the work group also recommended allowing coursework in biomechanics to substitute for college physics for those applicants without an associate's degree. Shortly, I will go through that actual proposed rule text, but in the meantime, does anyone have any questions about the work group report?
Catherine Mize here. I just want to clarify the two things, and just using my own words, that the work group is recommending. What I am seeing is that they recommended two changes. One, so that a biomechanics course could replace a physics or be used in lieu of a physics class that was worth 3 hours. And the second one was that they wanted to allow an associate's degree with substantial coursework in anatomical, biological, and physical sciences be a pathway to an assistant licensure.
That's correct.
That would be correct? Okay.
Yes.
Because okay, so any other comments before we move to the wording?
Okay, I'm going to stop sharing my screen.
Stephen Leary, Assistant General Counsel. I think we need a motion to approve the work group report.
Okay, if we do that, we're not approving the actual wording that has been
No,
proposed.
you're just approving that it's gone back from the work group and they've given their report.
Okay, I'm sorry. I just want to be clear. The wording that has been drafted, in my opinion, does not reflect what the work group intended. So I just want to make sure that we're not approving the draft language.
Okay.
Sorry.
I don't think it matters. I think it's
So in that
traditional
case,
to accept the work group report that is the work group report, or to make a change to the work group report. So you can make a change to the work group report if you don't think that's what the work group did or discussed. But when we get to the actual rule item, then if you wanted to change the language in the proposed rule, that would be the time for that.
all right. Then in that case, do we have a motion to approve the findings of the work group?
I motion to approve the work group's report.
Do we have a second?
Question, can we second this with discussion on the new language?
Absolutely.
Second,
Well,
Mark Kirchner.
so let's clarify this again. I think what Mark and I are both saying is that we can approve the findings from the education work group and their intent, but we do not want to approve the draft changes as have been suggested in the draft language for 114.27.
That is correct. That's my understanding of what the motion was and what the procedure is. So you're accepting that was the work group's recommendation, but you're not accepting their actual recommendation. Here. When we get to the underlying item, then Cassie will present the what the draft rule is, and then you'll discuss it, and then you'll either approve it or disapprove it or make a change to it.
All right. So Mark, with that explanation, do you still want to second?
Mark Kirchner, I'll second it.
Do we do a roll call again?
Yes.
Okay.
David Arends,
Aye.
Mark Kirschner,
Aye.
Eric Olson,
Aye.
and Presiding Officer Catherine Mize.
Aye.
Motion passes.
All right. So now we're going to proceed to discussion about the draft proposed rule changes to 114.27 to reflect what the work group has intended.
Yes. Cassie?
Okay. Yes. Okay. Good morning again. Cassie Sopstead, Assistant General Counsel, TDLR. I will share my screen shortly, but just first, in summary, I am going to discuss the proposed changes to rules 114.27, 114.67, 114.68, and 114.69. Based on the recommendation from the Education and Examination Work Group, the proposed rule changes modify the requirement that assistant license applicants take a physics course prior to licensure and provide an option for applicants to take a biomechanics course instead. Additionally, the proposed rule changes provide a pathway for applicants with Associates of Applied Sciences degrees to qualify for licensure. The proposed rules further clarify that although a license application and supervision agreement must be received by the department prior to beginning the clinical residency portion, the applicant is not required to complete the education requirements before beginning residency. Additionally, organizational and cleanup changes were made to the rule. Now let me share my screen. Okay, Can everyone see my screen?
Yes.
Great. Just a reminder, the underlined text is the new language, the strike through is the deleted language. So I think the best thing for me is just to go through 114.27, the proposed changes, and then we can talk about it afterwards if that works for you guys. So just kind of going line by line here. The heading for subsection A was changed from qualifications to issuance of an assistant license to better reflect the scope of the rule. This was modified to clarify TDLR will not issue a license until the applicant has completed the education and clinical residency requirements specified within the rule. And please, if at any point I'm going too fast, please tell me to slow down and I will slow down. Moving on here to subsection B, education. This has been added to clearly state the educational requirements. Underneath education, existing subparagraph AIC, please again tell me if this is confusing, has been redesignated as B1C and reflects the new biomechanics course option. So you will see here under C, they can now take either physics or biomechanics. Then scrolling down just a little bit, new paragraph B2 contains language regarding the new Associate of Applied Science degree qualification pathway. And then again, going down, now we're looking at, go ahead.
Yes, this is Catherine Mize. If we can
Sure.
pause right there. I agree with C, the 3 credit hours of either physics or biomechanics. My question is on 2, the description of the applied sciences. To me, this description does not reflect the wording of substantial coursework in the anatomical, biological, or physical sciences. So I'm just wondering if we can clarify when you read number 2 that those courses have to be a part of that associate's degree.
Sure. One comment on that, and then Stephen may jump in because I took over this rules package from him, and so he may have a little bit more of the background than I do. But one thing, Catherine, I can say for sure on that piece, when we went through this and we were making edits, one of the things that came up was wanting to steer away from saying substantial coursework because that was more subjective in nature. Like, what does substantial mean? So I understand your perspective of, hey, can we clarify? Can we actually list those things out? And that seems to be like something potentially we could do. But I just wanted to give some context for why we removed the substantial coursework piece. And Stephen, I don't know if you have anything else to add.
Well, I was there during the work group meetings, with one of the board members is not here anymore, but I was there, and that, they wanted to have that associate's degree pathway. In a previous version of this rule, I had that in there about substantial coursework. I think we could certainly add it back in, but as you mentioned, it might be somewhat subjective. So that's something that our E&E department would have to look at on kind of a case-by-case basis about whether or not that particular degree program required substantial coursework. And that is the statutory language. One approach would be to put that back in there. I think another approach would be to specify, what program it has to be, or specify what specific courses you have to take. I think the idea was, in the work group discussion, was that there are people who are experienced healthcare professionals, whether they're occupational therapists, physical therapists, nurses, and so forth, and that if they have that kind of a degree, that it would be assumed that they have enough scientific knowledge that we wouldn't require them to take physics or biomechanics. So, yeah, Mr. Olson, I think, has a comment.
The we can knock that out by just changing it to associate of allied health degree instead of applied science. It should be allied health. There you go. That covers all your occupational therapists, PTs, nursing assistants, dental assistants. That's all applied or allied health degrees.
Well, let's pencil that in as a possibility, and then once we get through the presentation, if someone wants to make a motion to approve it with that change, that's fine. If you want to make a motion to disapprove the whole package, send it to a work group, make another change. We're really not at the level yet or the right juncture to change the draft. That'll come after the presentation when someone makes a motion, but we'll pencil that in.
Get May I just want to put this out here, not asking for a change. I would then, my expectation would be if someone applies that doesn't have that allied health degree but has an associate's, that would be taken on an individual case.
All right. Catherine Mize here. If we are pointing to this coursework in the first pathway so specifically, 8 hours of anatomy, physiology, etc., I don't understand why we can't point to that specific coursework held within an associate's degree.
Because these requirements of the 8 hours of anatomy, physiology, and stuff are higher amounts than are part of some of the associate's degrees. And it'd be horrible to say, hey, you've got an associate's degree as an occupational therapist, but you don't meet these, you're going to have to go back to school. That's why we made it an either or. If you don't have a degree, you've got to have a minimum of this stuff. If you have a degree in applied health or allied health, then you're good to go.
I see. So Catherine Meister again. Okay, I see that intent. I just can't say, I don't have enough knowledge about the coursework required in all allied health programs. And I would have to say a dental assistant, if they have an associate's degree, they are not qualified, in my opinion, to become an assistant in O&P. So I want us to really be careful about this wording, especially since or is the conditional to two.
Okay, great. Can I move forward now? Is that okay? So I made a comment there, so we know we can come back and chat about that. Moving down now into the clinical residency hours. New subsection C is titled clinical residency hours. This has been inserted for clarity, and this subsection describes the clinical residency hour requirements for each assistant license type. So then you'll see, I'm going to go down. New subsection C4 has been added, that's down here, to describe the facility requirements for completion of the clinical residency hours. You can see what I did. I essentially removed that from each piece and just put it in one place at the end. Okay. Going down to now new subsection D. So that was the existing subsection B has been relettered as D and changed to clinical residency and supervisor requirements to more accurately reflect the scope of the subsection, and the requirements that follow under the new subsection D have been renumbered. So the main change here, you can see we've added in under new subsection D, D1 definitions to make it really clear what a clinical resident is, and then also what a supervisor is. And then again, as I discussed previously, here under new subsection D2, and D3, we talk about, hey, first, we need to have the application and that supervision agreement on file, but you're not required to complete the education before you start the clinical residency. So we just wanted to make that really clear what the process was. And then the next piece, the supervisor cannot allow the residency to begin until we, TDLR, have received both that supervision agreement and the license application, and we've approved the supervision agreement. We made sure to just say approves the supervision agreement because, of course, as we all know, they're not actually licensed at this point. And then, as I said, you can see we've renumbered, added, everything underneath has just been renumbered. I added in under 5, made it clear that's clinical resident. Since I added in that definition of what a clinical resident is, I just made that clarity throughout. And then I'm going to scroll down now to, here's another addition of saying assistant license level work. And then coming all the way to the end, existing subsection C has been relettered as E, and that has been changed to scope of assistant practice and supervision. This was done to more clearly reflect the scope of practice once the assistant is actually licensed. I did not make any other changes under here as far as scope. I know that will be a to be continued discussion in a work group. But that is the crux of the changes that were made, or proposed changes to 114.27. I'm going to open it up now if we want to chat about it before I move to the other unrelated items. And please tell me if you want me to scroll back up, if you want to see anything. Yeah.
So Catherine Mize, on the page number 3, section E, scope of assistant practice and supervision.
Yes.
I personally find that wording confusing. Scope of assistant practice. Scope of practice for the licensed assistant, perhaps.
Yep. Okay.
But the phrase scope of assistant practice is odd for me personally. I don't know what others think. So I would suggest on that wording, scope of practice for the licensed assistant and supervision required. That's a lot of words. Or just maybe and supervision would be a suggestion.
Would it make
What if
sense
we
to
use a
you?
semicolon there and do scope of practice of assistant, semicolon, supervision required? Something like that.
That would work for me.
Sorry, what was that? Scope of assistant?
No, scope of practice.
Practice. Got it.
For the licensed assistant.
Let me minimize that so I can see what I'm typing. And semicolon supervision.
Supervision required. Is I believe what he said.
Yes, that's what I had suggested. That seems to capture what Ms. Mize is saying.
Okay.
So Catherine Mize, I'm going to personally state that I don't have any issue with that word changing there. I don't have any issue with anything else except for what we were previously discussing on item number 2 on page 1 of this document, where it says graduated from a college or university. I just think we need to look more closely at that and what type of associate's degree, or what elements within an associate's degree need to be achieved.
Okay.
I'm not prepared, nor do I have the knowledge sitting here today to propose or even approve of wording around this statement.
So I'm going to speak for Steve Eager because he said he's having some computer issues. His suggestion is, sorry, my computer, hopefully mine doesn't go on the fritz here too. Let me go back up. So his suggestion is for B2, adding applied science or allied health with coursework comparable to requirements in B1. Do you want me to type it out so you can see what that, so you can read it? Or
And those, the comparable coursework, would that be at the discretion of TDLR?
Well, this would be looking at those 8 hours of anatomy and physiology, 3 hours of medical terminology, and 3 hours of either physics or biomechanics, and looking at the transcript, which we do all the time, for something that would be covering that. So, they have some kind of biotechnology course or some anatomy courses but maybe not 8 hours. I don't know, but looking for comparable coursework, comparable time. Medical terminology is something that's, I feel, is usually covered in just the process of getting a degree in the allied health, profession, and physics and biomechanics. I think having that ability to giving us some flexibility on that will be helpful. But basically incorporating what is already listed in B1. And then what we do is we go to the course catalogs for those universities and look at the course descriptions and see what is this class covering, if there's a question.
Steve, let me ask you a question. An Associate of Applied Science degree, could that be in geology?
Yeah, that's a stretch. So they would need that. That's what I'm saying. We want that.
Right. So that's my point. The term Associate of Applied Science it's way, way too broad. But it could be narrowed by, like you said, looking back to the coursework required that's listed above. I guess my only concern there is truly determining if the coursework is comparable. So anatomy and physiology, that's not of animals and bugs. There's a lot of different. In a medical terminology class, you could have an associate's degree that did not have any medical terminology, but that is a very easy to pick up course that could be taken outside of that associate's degree. So in my opinion, you could have an associate's degree that hit on some of these, but did not hit on all of them. And perhaps you would have to go back and pick up 1 or 2 more courses to supplement it.
And we routinely tell people to do that.
Stephen Larry, Assistant General Counsel. One thing I wanted to suggest here that might be an easy fix and it might not, but if we were to track the language from Occupation Code 605-255 and insert it there, that it requires substantial coursework in the anatomical, biological, and physical sciences. That's the way we had drafted that at one point, and that got taken out. I think that would answer some of those concerns, that if it's an associate's degree of applied science that they're using to qualify, then it has to have that substantial coursework in the biological, physical, and anatomical sciences as determined by the department. That means we take it case by case. So that would be one approach. Another approach would be to require a specific number of hours. But I think the idea was that people who are healthcare professionals, that they would would have enough scientific experience, but we didn't want to make it an automatic, and we wanted to be looked at case by case. I just want to throw that out there.
Cassie
Okay.
Sopstead here, Assistant GC with TDLR. Would it be helpful to you all if I just typed that suggested change, perhaps incorporating both what Steve and Steven suggested? Maybe we can say with an Associate of Applied Science or Allied Health degree, and then put with substantial coursework in XYZ.
Yes, you can go ahead and type that out. And do we have any other comments from board members?
Stephen Larry, Assistant General Counsel, before you do that, I wanted to point out that there's another part of this rule package that implements symbol 2075 that's making changes having to do with the advisory boards. So we kind of paused here, but Cassie didn't yet get a chance to explain that. So I just wanted to, it made some changes to the term of the presiding officer, the term of the board members' terms, and it was a statutory change that we had included with this package. So I don't know if you wanted Cassie to go over that before you close out the discussion of this rule.
I guess I'd like to complete the discussion of this rule and see if we can reach consensus.
Okay.
Great.
I like what you're doing where you're saying comparable, because what we really want to do ultimately is create more pathways. We want to end up with qualified people, but we want to create more pathways to get there. And I think you're accomplishing that with this.
Eric, Cassie Sopstead, Assistant GC here. Do you have a leaning one way or another with saying substantial coursework and I'll type out what those courses are, or did you prefer the comparable or coursework comparable
Yeah,
as
comparable is a very good word, a very good, because it gives them a definition. I want someone to be able to read the education requirements for an assistant and go, well, I have an associate's degree. Is it comparable with what I'm reading up here? Yes, it is. I'm going to apply.
And Steve Larry, Assistant General Counsel, the term substantially equivalent is a term that we use a lot in our rules that has basically the same meaning as being comparable. So I think just to be consistent with other rules, we might want to go with substantially equivalent if
That's fine.
if that's the concept we're going for about it being comparable, being similar.
Yeah, I like that wording, substantially equivalent.
okay. Cassie Sopstead, Assistant GC, TDLR. What do we think of this language that I've added? I'm just going to read it out loud and you guys can see it on the screen there. Associate of Applied Science or Allied Health degree with substantially equivalent coursework in the anatomical, biological, and physical sciences.
Perfect.
Catherine Mize here. Do we need to then state that it is reviewed on a case-by-case basis and accepted, or however you want to word that, on a case-by-case basis by TDLR? Subject to review.
Maybe Cassie Sopstead, Assistant GC with TDLR. Catherine, what do you think about that?
Okay. Do you need to be more specific with acceptance or denial or modification to courses? Or does that wording cover it?
could insert an hour requirement.
Okay.
But what is a associate's degree in allied health? How many hours of science are
This
included
this
in
is
that?
Eric. This is Eric. The deal is that we have someone apply that has a associate's degree for physical therapy assistant. It may not reflect the hours verbatim, and that's why we would want to have it comparable, because if the hours aren't identical, they have 7 hours of anatomy instead of
Mhm.
8. We don't want them to have to go back to school, because that will block another gateway for us to acquire more assistance in Texas. So I would leave the hours, the verbatim hours out.
Okay.
Just comparable,
Right.
substantially equivalent.
Yeah. Yeah, I know. I mean, that's the whole concept here, is to get more assistance out there.
Yeah.
We're all in agreement on that.
Catherine Mize, is there any way, Eric, I understand your intention here and I like it,
Mhm.
but applied science, and I don't know if there's a botany applied science associate's degree or a geology or all of these other areas that would have almost no substantially equivalent. So I guess what I am asking this group, does this wording take those folks that have the associate's degree in applied sciences, and does it prevent them from obtaining a license with the wording substantially equivalent? What's the leeway when you review, what's the leeway of substantially equivalent?
Yeah, substantially equivalent anatomy of the prokaryotic or whatever of a plant, not gonna make it. So we're looking to those requirements in B1 for substantial equivalence.
Is there a legal definition of the term substantially equivalent?
Steve and Larry?
I don't know if there's a legal definition of the term. That term is used in the rule about uniquely qualified individuals. It's something that we've looked at. I'd have to take a look. But it's not legally defined. It's not defined in the Act. It's not defined in the rules. It's a term that is used, and it basically means what you just said, that we're going to take a look at it on a case-by-case basis and determine that if it is sufficiently similar or comparable, basically. It doesn't have to be exactly equivalent, but it has to, in a substantive way, be equivalent. So it's a term that's used, and it basically essentially means comparable.
Okay, let me ask this question, Catherine Wise. Who is the we that reviews this to determine substantially equivalent?
No, Steve and Larry, Assistant General Counsel, that would be the department staff. That would be our either our Education and Examination Division or our Compliance Division.
It'll go to compliance. It'll go to myself and Ari Acevedo.
Okay.
Heather Muir, Licensing Director. It initially goes to licensing, and if the licensing staff has an issue determining whether it meets or not, then we do reach out to Steve Eaker's team, as he said. But the initial review goes to licensing.
So Heather, thank you, Catherine Wise. The people on licensing that are looking at this, are they qualified to make that call?
Initially, we probably would need to do some training for them to understand. It's kind of like it's taking something that's very clear and making it a little ambiguous. So what is substantially equivalent? Does that mean they don't have to have any physics or biomechanics since it's only 3 hours? Is that something that is important for you to have in someone who's going to fill this role? there was a conversation about 7 hours of anatomy and physiology versus 8 hours. Is 5 hours okay? Is
Right.
6 hours? Is 3 hours? So it's kind of like, where are you drawing those lines and trying to figure out where that is? And we may reach out to an advisory board member as well for direction for a little while to kind of, what will happen over time is as we kind of get these applications coming in, we'll develop kind of like a list that says, okay, this was acceptable, this was not, this was not. And so we'll kind of build that knowledge base as we go through the process of implementing these changes.
Catherine, this is Mark Kirchner. Question I have is, can we send this back to the work group to make it more specific so that we don't go through this? How do we decide if it's 7 hours is good enough or 5 hours is good enough, X, Y, Z? I think it's a lot to try to put this together right now, but I think it needs to be more specific.
Yes, Catherine Mize here. I tend to agree with Mark. I'm uncomfortable with this. I like the direction we're headed, but I am slightly uncomfortable. And Heather, to your point, you build a case over time on how to rule on these, and then we have turnover, as we do with any agency and any employees, and so it kind of starts over. And if I knew that we had somebody in education and in orthotics and prosthetics, Mike Mojica, who's one of our board members, that could cast eyes on these applications, I would feel 100% covered, that we had a set of eyes that were truly knew what they were looking at as substantially equivalent. I'm just, can we send this piece back to the work group?
Stephen Leary, Assistant General Counsel. I just wanted to interject here. Well, absolutely, you could send this whole thing to the work group. There is a separate part here that Cassie hasn't gone to. I want her to have a chance to present about Senate Bill 2075. It's completely unrelated to this, and if we can get your feel on that, we could possibly advance that second part of this that cleans up the advisory board provisions, and then take all this out of this rule package, send to work group. So if we could, I would like for Cassie to get the opportunity to present that second half of this package before you decide what to do with this part.
I think that's great. Cassie, let's go to the second part.
Catherine, can we take 5? Can we take a 5-minute break?
Yes, we can.
Sure.
I think there's official language I'm supposed to use for that, Mark. I would like to officially take a 5-minute break, and we will resume at 12:28.
Thanks, Catherine.
Thank you. The meeting for the Orthotists and Prosthetists Advisory Board today at 12:28 p.m. Again on October the 14th. Thank you. And Cassie, you were going to continue with your next section.
Thank you, Catherine. Cassie Sopstead, Assistant GC with TDLR. Before I jump into the rule changes related to SB 2075, I am just going to suggest that we break that off completely from the 114.27, since I know you guys recommended that go back to the work group. So I just wanted to make that clear in the meeting that we are going to split those two things apart. Okay.
Thank you.
Let me share my screen, get down to those changes. Okay. Okay, is this clear to everyone?
Yes.
Okay, so in short, the proposed changes to Rules 114.67, 114.68, and 114.69 implement provisions of Senate Bill 2075 from the 89th Legislature regular session, which standardize the advisory board related statutory provisions, including members serving staggered 6-year terms, changing the presiding officer's term to 2 years, and this also repealed provisions relating to the board's ability to call special meetings. So specifically, if we're looking here at the top at 114.67, advisory board terms and vacancies, as I said, now this is standard across the board. Members of the advisory board serve staggered 6-year terms. The rest of this rule remains unchanged. If you guys have any questions about this as I go on, please let me know. Moving on to 114.68. This is advisory board officer. As I said, this increases the length of the presiding officer's term from 1 year to 2 years. Everything else remains unchanged. And then lastly, 114.69, which is related to special meeting, well, not just special meetings, but those are the provisions that changed. As you can see, 114.69 C, subsection C and D were both repealed. And like I said, what that does is that just repeals provisions related to the advisory board's ability to call special meetings. Do you guys have any questions on any of these specific changes?
Catherine Mize here. I don't believe we ever called a special meeting as an advisory board, but with these changes, is there any way to for us to initiate the need of a meeting to be held?
That is a great question. I may have Steve and Larry jump in since he is on our advisory board team. So
Sure.
Stephen.
See you, Larry, Assistant General Counsel. So yes and no. What you can do is you can reach out to our advisory board coordinator and tell them that, hey, we haven't had a meeting in a while. Would you set a meeting? But what this eliminates is they repeal the part of the statute that lets you directly call a meeting. So the reason for this is with the number of programs that we have at TDLR, there are many differences in our advisory board provisions. I'm also on weather modification, for example, and our board was called a committee. It wasn't called an advisory board. There are many different statutes about how long each board member's term lasts, and various different special provisions and different programs. That ended up being a lot for our advisory board unit to keep up with. So Senate Bill 2075, it repealed parts of the program statutes that made different advisory boards different. And that particular part there, that was a part that got repealed in our chapter 605 in our statute as part of this bill. So the reason for the rule change was simply because the underlying statute that allowed for you to call special meetings, it got repealed.
Okay, so it's my understanding from what you said then that we could still bring a matter up to TDLR and ask that a meeting be considered to discuss a problem or a concern.
That's right. Yes, and the statute that formally allowed you to formally call a special meeting, it's no longer on the books. It's been repealed. So because that rule implemented that statute, that's why we're seeking to repeal that rule.
All right. Any other questions or comments from the board? No? All right. So would it be appropriate at this point for us to make a motion and a second to accept the changes as presented for 114.67?
Cassie Sopstead, Assistant GC here. So that would be 114, 67, 68, and 69.
All right. Does someone on the board want to make that motion?
As Mark Kirchner, I make a motion to accept 114.67, 114.68, and 114.69.
Thank you, Mark. Second?
David Arns, I second.
Thank you, David. Carmen, will you do the roll call?
Yes, ma'am. David Arens,
Aye.
Mark Kirschner,
Aye.
Eric Olson,
Aye.
and Presiding Officer Catherine Mize.
Aye.
Motion passes.
Thank you.
All right. Proposed amendments, discussion of the Medicare. Okay, next on our agenda, item K, discussion of Medicare billing and consumer protection requirements of Senate Bill SB 1330 that was in the regular session of 2025 and possible rulemaking to address these requirements.
Thank you. Steve O'Leary, Assistant General Counsel. So Mr. Eaker had talked a little bit about Senate Bill 1330, and I've included a copy of the bill and of the bill analysis in your materials. I'm going to go ahead and, if I can, go ahead and share up that the bill, and I'll walk you through a couple of things and kind of touch on some rulemaking related to this bill that we're starting to look into. We're starting to develop some draft language, but we're not quite at the level that we want to propose it at the meeting. So again, this is something that I think will be good for a work group. Not necessarily the same work group that the other package goes to. I think we currently have 3 different work groups, so we'll visit about that more when we get to the work group item. I'm now sharing on my screen what should be 1330. I believe you have Bill 1330 in front of you. So just to touch on this briefly, Senate Bill 1330 addresses the topic of surprise billing and overbilling for Medicare enrollees and what are referred to as Medigap or Medicare Supplement Benefit Plans. It created a new chapter in the Insurance Code, it's Chapter 566, that deals with this topic. It generally restricts non-Medicare participating orthotic and prosthetic suppliers from billing a Medicare enrollee more than 115% of the Medicare approved amount unless they take certain steps and give certain disclosures to the consumer. And this was particularly targeted at this industry, orthotists and prosthetists, along with some other durable medical equipment providers. So these, I'm showing up on the screen, you're looking at subchapter B of the bill of 566. This kind of gets into the what those disclosure requirements are. And So in order to do this, in order to charge more than 115%, you have to have them sign a separate agreement. They have to sign it before they receive the equipment. So before they receive the equipment or supply, they have to either pay the full additional amount or they have to enter into a rental plan. And it has to advise them that Medicare will reimburse 80% of the Medicare approved amount. And the Medigap, or the Medicare Supplement Benefit Plan, is not required to pay amount that exceeds 115% of the approved amount. So these are disclosures that are designed to let the patient know that they're going to be on the hook essentially for this additional amount. It also in subchapter C, it provides that these Medigap plans don't have to pay more than 115%, the amount that exceeds 115%. So that's going to be the consumer's out of pocket. It creates a cause of action under the Texas Deceptive Trade Practices Consumer Protection Act, or DTPA. That's our consumer protection statute in Texas that is used for false advertising, various practices which the legislature has deemed to be deceptive. It allows a consumer to file a lawsuit and to recover treble damages, or triple the amount of what the actual damages are. It also allows the Attorney General's Consumer Protection Division to file a lawsuit in the name of affected customers. So it creates a cause of action under DTPA. It also creates a criminal offense. Again, it's a misdemeanor offense that if the non-participating supplier intentionally violates this chapter, it can be fined for that. It doesn't directly affect or modify our program statute, chapter 605. But because our existing rules touch on some of these topics, rule 114.90, which is our professional standards and basis for disciplinary action, we have a rule already about flagrantly overcharging. And that's kind of a related topic. Some of this might fall into that. Violating this consumer protection statute might be something that would be a basis for disciplinary action. But it's something we probably want to clarify in our rules, whether or not we're going to enforce this, the extent to which we'll enforce this. We also, in Rule 114.70, we currently have the rule that implemented Senate Bill 490 from the last session about itemized billing. So we're looking at adding a section to that to deal with this topic of Medicare billing. And as part of our bill implementation process here at TDLR, what happens is after the legislative session ends, we break up into these bill implementation teams where we take on many different bills that have been passed. We take a hard look at what rule changes are necessary, what updates we need to make to the website, forms that need to be changed and so forth. And so we've begun developing some rules on this, but because it's an interesting topic, we're interested in looking into what specific kinds of safeguards we want to put in place for consumers, if we want to include this in our rules at all. Some ideas that have been discussed include requiring that disclosure agreement be in a certain point of font, that it be printed, that if the patient doesn't speak English, that it be translated, or that they be given an opportunity to review it in their language of choice. Various other things we could include in our rule to implement this, but at the very least, we may want to look into making it a violation of our program rules if you violate this bill. And so with that, I'll open up to questions. Thank you.
Thank you, Stephen. Catherine Mize here. I want to open this up by also saying that there are some existing rules within our field relating to how we bill Medicare and what we are required to have on file for a Medicare patient. And that relates to a document called an ABN, an Advanced Beneficiary Notice. And for us so there's the ABN is not completely simple, but there are some definite rules around that ABN and what it is communicating to the patient. It's a very specific form, and it is required that we keep on file and that we explain it to the patient appropriately and we have them sign it. So something like that could be incorporated to help the enforcement of this because it's something that's already done and practiced.
Thank you. Yes, and while you're doing that, while you're discussing that, I'm just sharing on the screen our existing rule 114.90. This is part of what we looked at is, what, without making a rule change, what rules might be implicated in this topic if someone were to overbill or not provide that consumer disclosure. And so a couple of the rules we looked at were here in 114.90C1 about false, misleading, or deceptive advertising. And then also we have in our rule about overcharging. But one problem we looked into here is that the rule about overcharging refers to persistently or flagrantly overcharging. And that's kind of questionable whether this falls into that. Those terms aren't really defined, what's persistent or flagrantly overcharging. So that's one rule that we're looking at. That's one place where we're looking at making this change. So I just want to throw that in there and give you and share up on the screen the text of the existing rule, and I'll allow you to continue. I apologize.
Is this something that's happening mostly with 5999 codes and 7999 codes? Is that where these overcharges are being done with Medicare? Is that what sparked it? Where they have items that aren't on a fee schedule?
I'd like to loop in Steve Eaker. I think if he's here. I honestly don't.
That would be a question before. I have no idea. You'd have to talk to CMS or where people are being overcharged. I am not a code specialist. You do have a quote for that at your conference, though.
Yeah, Catherine Mize here. It could be there, Eric, but it also could be that if you are a non-participating Medicare provider, that you can charge anything you want on a Medicare L code, way and above, 115% above. And so, and if you notify the Medicare person with the signature on the ABN, for federal guidelines from CMS regulation, you can charge anything that you want. It doesn't change what Medicare will pay you for that code, but it does change what you can attempt to collect from the beneficiary. And so this change, statutory change in Texas, is simply putting a cap on that at 115%. But it could be on any L code that we use. I don't know where the abuse was. I'm just saying it could have been anything.
Yeah, I was just inquisitive on where the abuse was.
And and the intent, I think, is, if you want a amazing prosthetic for scuba diving, nobody's stopping you from doing that. But if you want some reimbursement for that, then that will be limited to 115% of the base, whatever the L code is for that particular.
Right. To Eric's point, we have undefined codes that CMS has given us, and they end in 2999, 5999. They typically end in the 3 nines digits. And those are undefined codes. So we define them and we set a price to them of our own making. So there is no 115% of anything because there is no set fee to that.
This is Mark. So, but this is connecting back to what is billable through Medicare. The way I'm reading this is, if you're going to provide something else, like you're going to provide a scuba leg, they're going to pay you outright on that because Medicare is not going to cover it anyways. This is just so that underneath the ABNs under Medicare, if when we go through this scenario, is we're actually articulating to that patient what their coverage will be and we keep that on file. I think this is more from about bundled billing and that this is like 2 years ago, correct?
Yes.
So, so where do we need to go from here, Catherine? So where do we need to go from here?
Steve, does this recommend, or Mr. O'Leary, does this need to go to a work group as well? Is that what you had said earlier?
That's what I've suggested. We're independently working on some language, but I think some guidance from some of your technical expertise about what should go into this would help us. I think otherwise we'd be in the position we were in today, where we're kind of bringing a rule to you that you may not like, and that's going to get, you're going to have feedback about it anyway. So it makes sense to take it to the work group and get your technical expertise before we take it to a meeting like this. And
Yes.
I don't know how much feedback we need, but I think we need to work through how it's going to impact this industry in particular.
I think that's a wise idea, because you're crossing over into some billing practices that we already have some very strict guardrails on us from a federal level. So I guess you kind of don't have to recreate the wheel here. A lot of this is already defined in how we practice.
Right, and if we're going to do a rulemaking on this, it could be a fairly simple one where we just add a line to 11490 saying failure to comply with the Medicare billing requirements of Insurance Code 566. We could do something like that, or we could go the other way and have more specifics in the rule. And I think that's the kind of thing we need some guidance on.
Okay. So we will make the recommendation then that this topic also be referred to a work group.
Yes.
All right. Thank you. So where does that put us on the agenda? Hold on just a second. Let me find my agenda. All right. Work groups. Next agenda. Work group assignments and possible tasks. So if I have written my notes correctly, I have 3 items that we have identified that we're going to go to work groups. And that was the Senate Bill 918, Chapter 605, cleaning up the language for unique qualifications.
Mm-hmm.
And then a second work group for that was recommended to go to the standard of practice work group that would deal with the licensed assistant wording and clarification presented around the topic that Hanger brought forth. And then the third work group would be this last one, Senate Bill 1330.
Yes, ma'am. And I think one other thing we might want to include with one of those work groups will just be our rule review. There's a 4-year rule review process where we got comments from within the agency about various different things in the rules that just need to be cleaned up. For example, there was something about a requirement about parallel bars in the rules that people thought wasn't applicable in every instance. There were a variety of just cleanup items, things that people thought were unclear. And I think it would be good, not all of those are necessarily worthy of discussion in the board meeting, but I think it'd be good just to have those rule review suggestions included in the work group assignment to one of the work groups.
All right. So I would like to, Catherine Mize, I would like to recommend that rule cleanup probably be given to the standard of practice group that's also going to work on the wording around the assistant license. And that's going to be quite the task. So anybody that wants to volunteer for this, I've done it twice, and I will volunteer to do it a third time, but it is, it can be extensive.
I, of course, will volunteer for it since it's my baby.
All right. So thank you, Eric. So how do we, what is the name of the work groups that would handle the Senate Bill 918 and 1330?
Carmen, you may have to help me with this. I understand currently we have 3 work groups, and the members may need to be updated on who's on the work groups.
I believe we have education, enforcement, and the standard of practice.
That's correct.
Yeah, and I think the language before was standard of care, but we can just update that to standard of practice.
Yeah, either one.
Okay.
So the two, Senate Bill 1330 could go to enforcement, perhaps.
The enforcement work group had you, Mark Kirschner, and then an empty spot.
And who is on the standard of care or standard of practice?
You, David, and then we can put Eric.
Right. And then who was on the, what was the third one I said? Education. That was Mike, Mojica.
And Eric, and an empty spot.
All right. And you know what? The unique qualifications, Senate Bill 918, that needs to fall under education. In my opinion. Does anyone agree or disagree?
I agree with that.
All right. Does anybody want to change the work group they're on or ask to be put on a different work group? Can we have a point of order or something? Can we have 4 of our board members on one work group?
No, 3 max.
3 max.
So for education and examination work group, you have Mojica, Eric, and an empty spot.
Yes. All right. So does anybody, okay, we're going to ask for a volunteer if anybody wants to move to that group. The group where we already have 3 people for the standard of practice or standard of care, myself, David, and Eric. Eric, you've expressed interest in remaining. I've expressed interest in remaining. David, would you like to remain on this group or would you like to shift to a different one?
No, that's fine. I think I'm more involved in the standards of practice than I would be in education. So.
Okay. All right. Then we'll keep that group as is. So, enforcement. I'm on enforcement. Mark's on enforcement. We would be handling Senate Bill 1330 that was just discussed. Does anybody else want to volunteer for the 3rd spot on Senate Bill 918 on the education work group? We have Mike and we have Eric.
Put me on that one too.
You sure?
Yes, David, yeah.
All right, David, thank you.
Was that the education and examination work group or the enforcement work group?
Enforcement.
No, I was asking about education for the unique qualifications.
I'm sorry. I thought you were asking about enforcement. No, education's not me, but I would be glad to be on the enforcement one. So if you need another position.
Okay, so we're adding David to enforcement. So then we still have the 1 spot on education. And if nobody wants to take that one on, I will add myself to that one as well.
Catherine, can I make a recommendation?
Yes.
Heather Muir, licensing director. The unique qualification is really looking at how their experience is related or equivalent to education. So that might actually need to go to the standard of care work group and not really the education piece, because they're not really looking at an education piece of it, if that makes sense.
Well, they're not looking at the education piece of it, but they're looking at substantially equivalent, maybe, in their experience. So I'm
Up to
speaking
you.
for Mike Mariska, and who's not present today on this meeting, but he has been very, very involved in that piece of it, and I think he's going to want to remain involved.
Okay, well, we will make sure that we have licensing and compliance in those meetings with y'all as well.
Okay. I think that would be great. Yes. All right, so we have our assignments for our work group.
Cassie
And
Safstead. Sorry.
Mhm.
Cassie Safstead, Assistant GC here. I just wanted to get a little bit of clarification. Are we combining the recommendations that Hanger made with that education piece from 114.27?
They're separate issues.
Okay, I just wanted to get some clarification on that piece.
Yes, so thank you, Cassie, and that is true. So the education piece on the assistant that we were discussing earlier and set aside, we can move that to the education work group.
Okay, and
Okay.
just another piece of clarification on that. Are we in agreement on the biomechanics piece of that? It's more really fleshing out that B2 language of the coursework.
That's
Correct.
correct.
Okay, thank you.
Yeah, thank you, Cassie. Good clarification. All right, so now that we have the work group assignments, who will set the meetings, and when will those meetings occur, and how will people be notified?
Stephen Leary, Assistant General Counsel. I want to point out that because we're going ahead with publication on the Senate Bill 2075 rule about the advisory boards, we'll need a second advisory board meeting to discuss any comments that come in on that item. So, the next step is we already asked for governor approval for that package. We'll let the governor's office know that we're only pursuing that part of that package at this time, and that we're taking out this part. And then we're gonna once we may have to update our fiscal impact statement. Probably won't. So after this meeting, we're going to publish in the register. There'll be a 30-day comment period, and then we're going to come back for another meeting. So just want to keep that in mind when we're talking about when the next meeting is. That we'll need one relatively soon to advance that part of the rulemaking, probably within the next few months.
Yes. How quickly are things getting published in the registry right now?
I don't know. It'll take a while just because we're waiting on governor office approval. But once we actually do publish in the register, it's not that there's a delay in the registry publishing it or register publishing it. It's the internal steps we have to take before we submit it to the register. So there's a couple extra steps we have to take. We have to update the governor's memo, and after that, we should be able to publish it fairly soon. But whenever it does get published, there's a 6-month time limit to adopt it after it's been published. So, ideally we'd have a second advisory board meeting within that window, and then have the commission meeting within that window. So just to keep in mind, as far as our next advisory board meeting, we'd want one probably the next 3-4 months from now.
All right. So it's also in my opinion, that if our work groups could meet, there is a chance that the education work group on Senate Bill 918 and the education language for that licensed assistant could be prepared within 4 months to present new wording at the next board meeting. And probably the enforcement group could be prepared to advance wording on the Senate Bill 1330. I'm not sure that the standard of practice or care work group will be completely finished if it's going to include a rule cleanup as well as the hanger recommendations. But that's something that we could try to aspire to for the next meeting.
And Catherine, just to answer your question from earlier, Heather Muir, licensing director, each work group has a TDLR assigned staff member. That staff member will do just like Carmen did for this meeting. They will pull the members of those work groups for dates and set the agenda. And so that's how that works, and that's how those get scheduled. Just to answer that question.
Can you share the names? Thank you, Heather. Can you share the names of each one of those TDLR people that have each one of these work groups?
Carmen should have that information.
It was not on the work group assignments, but
Oh, sorry.
I would assume for standard of practice, would that be Steve?
Then yeah, we'll get it scheduled.
Okay.
I don't mind putting in
And
the work. If you want to try to get it done within the 4 months, I'm up for that.
Well, we can try. I'm just not sure that will be achievable, but I think the other two are. Do we have names for the TDLR representative for enforcement and for education at all?
I can reach out and get back with you.
Okay. All right.
So
All righty. Then moving forward, it is to set agenda items for the next board meeting. So are there any recommendations other than, I guess, the ones that I have just made, which is hopefully to get at least 2 of these on the agenda, and maybe the third one if we're incredibly fast? Are there any other agenda items that other people would like to see on the next agenda?
I don't have anything.
All right.
No.
Okay. Hearing none. Discussion of date, time, and location of the next board meeting.
it looks like we were trying to maybe get in next 4 months, and I can pull out. We'll see how the work groups progress.
Okay, I'm sorry, Carmen, your mic was cutting out such that I couldn't hear you. How would we go about setting the next board meeting? You'll send an email?
We can monitor the work group progress, and then probably like the 4 months, how you were saying, 4 months out around that time, and I can poll you all and get that on the board.
So if my math is correct, we would be looking at maybe a late February timeframe, early
Yes.
March.
Fingers crossed.
Okay. All right, so we will just wait to hear then from you, Carmen, on that.
Yes, ma'am.
All right. Any other items that we need to, or that I've messed up on that we need to clarify before we move to adjournment? Hearing none, I move to adjourn this meeting of the Orthotic Prosthetic Advisory Board at 1:07 on October the 14th. And I thank everyone for attending and their participation.
Thanks. Y'all have a
Thank
good
you.
day.
You too.
Thank you.